would you like to read the history of the first case?
Yes, ma'am. A 65 years old male presented with complaints of intermittent breathlessness and fetal edema for 6 months. It is a known case of MI on antiplatelets. On examination, anemia was present and no hepatosplenomegaly, lymphadenopathy, and bleeding manifestations.
Okay. So from the history, what do you think? I mean, the main complaint of the patient is
Main complaint is like patient is having anemia from a long time, and it is like little bit like heart failure type. But just by the clinical history, it seems like heart failure patient, and patient is having anemia and fetal edema and breathlessness. All these are because of the heart failure only. It seems like this.
okay. So with this history, would you think that a bone marrow may be needed or no?
Ma'am, with this history, actually, to rule out the cause of anemia, that if there is any new erythroblast are forming or not in the bone marrow, for this we need to do the bone marrow. If there is any problem in synthesis of RBC.
So would you decide for doing a bone marrow only on this history, or you would want to first see the hemogram and PS and then decide?
First PBS, then.
Yes. Yes. So it's anemia and symptoms of anemia, I agree. Heart failure. Okay. So I have already shared this complete hemogram and PS. So would you just summarize what are the findings here?
Ma'am, here the hemoglobin is less, and RBC is a variation in shape and size, and we can see the target cells in RBC
Okay.
morphology. And
Okay.
ma'am, here and platelet aggregation of platelets are seen, and ma'am, WBC is not seen in this smear, and MCV is within the normal range. MCH, MCHC, all these are in the normal range, and platelet count is also normal. And on the total count is 4,490, and in differential count, neutrophil is 56, lymphocyte is 41, and eosinophil is 2, and monocyte is 1.
Okay. So you have a anemia and it's the MCV is on the higher side, right? Okay. So there was one more field which was given to you.
Ma'am,
Yeah.
here we can see one nucleated RBC in the field, and
Okay.
and one platelet clumps is seen, and spherocytes are also seen. Like there is lots of central pallor in the RBC.
Yeah,
And
some of these actually could be water artifact, but this is how the slide looked like. So I have taken this. So at this point, do you think bone marrow was indicated, or you can think of some nutritional cause of anemia? Do you think it is indicated still, or
yes, ma'am. Yes, ma'am. Because the timing is too much long, 6 months, and we can see the nucleated RBC, and
yes?
there was. That's why I think bone marrow aspiration is indicated.
Okay.
And
Could you think that this could be just a dimorphic anemia or nutritional?
ma'am, nutritional anemia, I will not think. It can be dimorphic anemia.
So there were some which looked microcytic,
Yes, ma'am.
slightly
Some cells are.
hypochromic, and
Yes, ma'am.
some
Yes,
are
ma'am.
looking macrocytic. So
Some are
there is
looking
an
macrocytic.
so
Some are
there is
looking
an
microcytic.
yes. There is an isopoikilocytosis and there's a nucleated red cell. So and it's a long-standing anemia. So
And one slide I saw one schistocyte like RBC also. Only one. It was only one.
okay.
In one of the PDFs.
Right. So so you feel that yes, it was indicated. Now I have put the questions here. It was in the slides that I had shared with you. It was at the end. So I have put it here so that you can tell what you saw in your findings, and then we'll go over because I've animated the slides. So what were your findings in the aspiration and pearl stain? Would you like to say?
Yes, ma'am.
Broadly, and the yes.
Yes, ma'am. Like in the aspiration, I saw erythroid hyperplasia, and on doing the pearl stain, it was like I was thinking of some iron. The iron was present, but the patient was unable to use the iron. Like sideroblastic like features after seeing the pearl stain.
Okay. So will you look for anything further?
Ma'am, yes, I can look for iron level, ferritin level, vitamin B12, and different the things which can cause anemia. All those things I will do. Iron profile mainly.
Okay. So with your initial impression, whatever you have formed, let us see the pictures which I had shared. So what do you think the marrow cellularity?
Marrow is normal cellular for age.
Okay. In fact, it looks a bit
Hypercellular for
hypercellular.
age.
Hypercellular.
Yes. And what are we looking here? These are which part of the marrow?
Ma'am, here we can see megakaryocyte and
That's right. So this is the rails.
megakaryocyte.
Yes. And here you have a macrophage. Okay.
Macrophage.
Okay, fine. And you can see that there is neutrophilic maturation which is seen. Megakaryocytes are seen. Okay. Then in this closer look, what are you seeing? More of?
More of erythroid precursor, and
Yes.
the one neutrophil is seen, and one erythroblast is also present, and
Okay.
mainly I can see here erythroid precursor.
So these are all erythroid precursors except maybe these two, right? This is a myelocyte, this is a neutrophil. So how does the erythroid look like maturation wise?
Ma'am, here I can see some erythropoiesis like features like budding, then like multinucleated, mainly budding type of erythroid.
Okay, in this field, what are you seeing here? What kind of maturation?
Some dysplasia.
What do you think is the color of the?
Oh, ma'am, basophilic cytoplasm. Basophilic
Okay.
cytoplasm.
And how are the margins?
Margins.
Yes. Okay. What about here in this field?
I'm like new. Ma'am, here like megaloblastic features. And they are little bit like.
Okay, megaloblastic features are also there, but in this one, again you are seeing fraying of the cytoplasmic margins, and you can see some vacuolation here.
Yes, ma'am, in cytoplasm.
Empty looking cytoplasm. So what would you think of? Can you make out here? I think I had shared these pictures.
Yes, ma'am.
Can you see this? Almost devoid of any immobilization in that. Yes, yes. And as you were saying, in some of the erythroid, there is what kind of maturation here?
Blast. This is erythropoiesis.
Okay, Rituraj, you are saying something?
Megaloblastoid.
Megaloblastic. This is sieve-like.
Sieve-like.
So there is, yes. Okay. And yes, what is it here? You had already mentioned.
Budding.
Budding. So there are features of this
erythropoietic changes.
This I think I had not shared, but again, showing erythroid budding. So with this, you have a cellular marrow with erythroid hyperplasia with some features of dyserythropoiesis. Is that right? And the maturation seems asynchronous, okay? And there is some amount of cytoplasmic vacuolization also you can see. There are some which are looking like micro normoblastic maturation, a few megaloblastic. Yeah. So what about the pearl stain? What does that show?
Ma'am, pearl stain is showing the iron is present. There is no deficiency of iron.
Okay. How will you grade this? Although it's not enough, you're just seeing two particles here, but they are full, and this is at a low part.
Yes, ma'am.
At least you can say whether it's normal or increased iron stores.
Ma'am, increased, not normal to increase.
Increased iron stores. Okay. Yeah. So this is a close-up, shows increased iron stores. All right. So as you had already said, where should I now look? I'm happy seeing the pearls or anything else?
Ma'am,
cytochemical stains.
Sorry? Rituraj, yeah?
Any cytochemical stain would have.
No, with the pearls, are you happy with this much, or with the morphology you want me to look somewhere else?
We'll also
vitamin B12 level and iron ferritin level.
For iron stain, we'll look for
sideroblastic presence.
Yes. Yes. Even in the initial slide I had said that in pearls, please make it a habit
See rings.
to look for
high power
yes,
and
ju-
look for
yes,
ring
go to the
sideroblast.
high power and go to the trails and look at the smear. So
Yeah.
can you see here?
Yes, ma'am. Rings.
Yes.
Yes, ma'am.
Yes. So you can see this ring sideroblast. So can you tell what is the definition of a ring sideroblast?
Yes, ma'am. Like here, it is the problem in delivering of the iron by the mitochondria to the heme. So that is why on staining we get that iron stain around the nucleus of that RBC nucleus. That's why it looks like ring sideroblast. Actually, it is erythroblast. So this is ring sideroblast.
Is there any definition to call it a ring sideroblast?
Yes, ma'am.
Erythroblast
Yeah,
having at least five
Five
granules
granules.
More than 5
and
granules.
covering
More than
1/3 of
one-third
the nucleus.
Very good.
nuclear.
Yeah. So you are right. So let us look at some more pictures. Can you see
Yes, ma'am.
numerous ring sideroblast? Okay. And some more pictures. Is it clear?
Yes, ma'am.
Yes, ma'am.
Yeah. So one more question I have. What do you think is the stage of the erythroid where you're seeing the ring sideroblast? Anybody?
Intermediate.
Intermediate, man. It looks like intermediate.
From the
Problem.
side,
This is
you
really
can make
normal
out, you
blast.
can say whether it's preferentially one stage or all stages. What do you think?
Nuclear size is
Rituraj?
larger.
Ciliary stage maybe, ma'am.
Anjal?
Uh,
There are
late
different
normoblast
stages.
All stages.
So different stages. Yeah. So it's not just the late normoblast or late erythroblast, it's seen in all stages. So is that important? Does it give a clue to the etiology? So maybe it can be answered in the chat box whether in which type of sideroblastic anemia, which stage of erythroid show ring sideroblast. Okay, we'll take it up later. So I think you had asked me for biochemical investigations, but I had kept it towards the last. So just see this. What do you think the biochemical investigation shows? What is the abnormality here?
Ferritin level.
Ferritin level. Even B12 is high.
B12
So
is
obviously
also
there
high.
was no nutritional deficiency. So I had asked you what was the indication for marrow. Of course, there are certain anemias which are nutritional where you don't need a marrow, but here it was indicated. And what does this PS show? I don't know if it is clearly visible. Actually, it's, yeah, sometimes you can see on the Romanovsky stain, papilloma bodies. These are
Basophilic
also iron
stippling
content.
basophilic stippling is also present in sideroblastic, like theoretically in this.
Okay. So in the bone marrow, in the pearl stain, this will appear as siderocytes. Okay, when it is in the erythroid, mature erythroid. Okay. So what is your thought on the marrow trephine? Did I share this? I don't think this was shared.
No.
Yeah. So you can see this and tell what is the trephine showing?
It is showing erythroid hyperplasia.
Yes. So it is actually quite cellular. It's a hypercellular bone marrow biopsy corresponding to the high cellularity that we saw in the aspirate, and there is marked erythroid hyperplasia. And please note that these are in maturation. You are not seeing a maturation arrest. There are those which are, I mean, a little immature looking, which are pro-erythroblast, intermediate, and then you have a lot of late erythroblast. Okay, so there is accelerated erythropoiesis in the bone marrow. All right, so this is how a close-up looks like. There are megakaryocytes are there seen, but relatively myeloid appears to be a little suppressed because it's more of erythroid. And we also did the CD34. Would it be good to do it?
Yeah, to rule out myelodysplastic syndrome.
Yes, increased blast we should rule out. Whenever it's an elderly, we are seeing ring sideroblast, but there was no increase in CD34. So what is your final diagnosis on this? What will you call it? So we have a very, yes?
Ma'am, CD34 is positive here.
It is highlighting the endothelial cells. It is not positive in the cells here, in the blast. Okay, so that is control positivity. So what do you think, Mishmi?
Ma'am, I will go for sideroblastic anemia.
Okay, that is also a broad category. So, sideroblastic anemia, what do you think it is?
Myelodysplastic syndrome, MDS.
Okay,
Ma'am, like
MDS. So,
then also we get in sideroblast in MDS.
MDS.
okay, okay.
Then we have to check
So,
for look 5q deletion and all those things like
ye-
for MDS.
okay. So, this was 2-3 years back. We had this case. We called it myelodysplastic syndrome, SLD, or single lineage dysplasia with ring sideroblast. So now a few questions. This was as per WHO 2016. So in a upcoming WHO, where would this come under?
Ma'am, in upcoming WHO, I think ma'am, low blast and high blast, that category is
Yes.
there. Then in here it will be MDS with low blast.
Low blast.
Yes, correct. And what about the broad categorization? You have those
Ma'am,
which are defined.
morphologically
Genetically
and
and-
genetically.
Yes, yes. So
And
you
in
have
in genetically we have three things, ma'am. I forgot that name. SF3, SF3B. Then one other was there. Two more are there. I forgot the name actually. In
okay.
genetically there was 3, and in morphologically also it was again divided.
Okay, okay. Anybody wants to add further? So you are right. If it is genetically defined, this would actually probably have SF3B1 mutation. Okay. But if you don't have it and there are more than 15% ring sideroblast, then it would be MDS low blast with ring sideroblast. Okay. All right. So is it clear? So we move on to the next case. Any queries? Anybody?
Yes, ma'am. Are the granulocyte series also so dysplasia, ma'am, in our case?
It was not very significant. I mean, it wasn't.
Because-
It was showing normal maturation.
Because in some of the cells we could not see granules properly, ma'am. So hypergranularity is one of the feature for dysplasia.
Yeah,
Is it
yeah, that is true. But actually, I have not focused many photographs on the granulocytic series, but it wasn't showing much dysplasia.
Okay, ma'am.
Acha, that brings me to another question. Now, do we distinguish between SLD and multilineage, or what do you think? The new classification?
It's based on blast count.
So
currently.
basically, that demarcation, I think, is more merged. So we don't have a single lineage and multilineage, but we have increased blast or
Blast
Low
and
blast.
slow blast. Yes. Okay. Any other queries?
Ma'am, there are a few queries. One is
yeah.
about in sideroblastic anemia, RBC will be microscopic, right? That is the query here. MCV is 99. So how do we still call it as sideroblastic anemia? I think you have already answered the question, ma'am. I just brought it up because it was in the chat box. If you would like to clarify that to the student.
Yeah, it is not strictly microcytic all the time, though we call sideroblastic anemia in the DD of microcytic hypochromic anemias, but often it tends to be dimorphic.
Yes.
And so that is the reason that you can, and here the MCV was high. It was actually 99.
Yes.
So dimorphic picture can be seen often.
I think that is another clue that it is rather myelodysplastic syndrome where
Yes.
macrocytic anemia is more common than the
Yes.
other causes of sideroblastic anemias. And
Correct.
ma'am, there is another question. What is the importance of ring sideroblasts seen in all stages? I'm not entirely sure. There are a lot of spelling mistakes in this question.
Actually, that was the question I asked, so I was expecting answer for that.
There was only one response to your question, ma'am, in the chat box.
And that's a question.
Late stage, but there were no other answers to that.
Okay. I think I remember reading very long back that in MDS it is seen in all the stages, but in acquired ring sideroblastic, sideroblastic anemia, it is preferentially seen in the late stages. So here we were seeing in all the stages. You can look up maybe in some old books, but I was expecting an answer. Okay. Yeah. Any other?
I think I
Yes,
believe
ma'am.
it's
Yes,
given in
ma'am.
Catherine Faulkner that early stages, all stages are involved in neoplastic processes, whereas
Yes.
in acquired ones, it is mostly seen in the late normoblast stage.
Absolutely.
Yes, ma'am.
So, yeah, okay, fine.
Ma'am,
So that's why I was asking.
Yes.
Yeah.
ma'am, I had a question.
Yes.
So was bone marrow aspiration performed before the biochemical results came, or after? Like, if had it been megaloblast, say folic acid or B12 deficiency, would we have performed bone marrow?
No, there we would treat first. If it is
Yes.
biochemically
Okay.
megaloblastic, yes.
Right. Okay. Okay, ma'am.
And there is
Okay.
another question. Is there any morphological clue for SF3B1 versus non-SF3B1 mutated MDS in the erythroid series?
I don't think so. That is genetically defined. But if you have that mutation, even with a lesser number of ring sideroblast, it would still be in that category.
Yes.
I agree, Rakhi. I
But-
totally agree. Yeah.
Yeah.
There is
Okay.
one question regarding, is there any role for flow cytometry in MDS?
There is some role. I mean, it's a general question, but morphology still is most important, and cytogenetics more than flow cytometry, I think.
Rakhi, can I come in?
Yes, sir, certainly.
I mean, I totally agree with you. It's a myelodysplastic neoplasm or myelodysplastic syndromes is a multidisciplinary diagnosis based on, like, as Dr. Rakhi has shown you. Flow has a role now. We do actually, because the flow, my colleague Prashant does it regularly for MDS to pick up subtle dyspoetic changes which you cannot pick up on morphology, because you can do millions of cells and those patterns are lost. We have maturation patterns of myeloid, monocytic, erythroid cells, all these cells, So, but I agree with Rakhi, it's not a gold standard, but now it is kind of, in our practice, we use it regularly. Yeah, thank you.
Sir, ma'am, another question. What is the role of counting erythroblasts in this case? I think the question is about in the Pearl stain, the role of erythroblast count in this case. That is the question written in the chat box.
I think it's mainly for the cutoff of ring sideroblast.
Yes.
And of course, erythroid becomes part of the myelogram as such. Like you would anyway do the myelogram with the entire, including the erythroid.
Created cell count.
Yes, sir.
Yes. Ma'am, I
Small
had.
query, ma'am.
Sorry?
To call it a ring sideroblast, ma'am, does it does the iron granule have to be in regular manner, or can it be dispersed haphazardly in cytoplasm, ma'am?
It has to be perinuclear.
Perinuclear,
That
yeah.
is most important because it is mitochondrial iron.
Yes, ma'am. So it does not have to be uniform in
No,
size.
you can have. In fact, in some of the pictures, there were like in 2 layers or so, but it was encircling still the nucleus.
So
More
pattern
than
of
5 grams.
perinuclear is important for labeling it as.
Yes, yes.
Okay.
Because sideroblast you can get even in a normal marrow. They
Yes,
can be
ma'am.
haphazard, but ring sideroblast are pathognomonic. They are abnormal.
Okay. So
It is
they are
because of their location.
okay.
Ma'am,
Yes.
one question. Ma'am,
Yeah.
there are like 3 types of sideroblastic anemia. Is there no 1, 2, and 3? So like 1 is for normal people, like normal, and type 3 is abnormal. And type 2, how will you differentiate between type 2 and type 3? That granules.
I am not very sure of which classification type. You are saying sideroblastic
Yes,
anemia or
ma'am. Yes, ma'am.
sideroblast?
Ma'am, sideroblastic and sideroblast. These are of 3 types. Like one
Okay.
is for normal and type 2 and type 3. How can we differentiate between type 2 and type 3?
I am not sure of this classification, but just as I was telling to Rituraj, sideroblasts are normal. Even a normal bone marrow will show sideroblast. If you have good iron stores, you can see where it will be dispersed sideroblastic or iron granules in the erythroid. But when it is encircling the nucleus in a perinuclear manner, and it is a ring sideroblast, that is abnormal.
Okay. Okay.
I've also read the same book. I think
think-
I've also read the same book, ma'am. It was probably Essentials of Hematology. There is written type 1, type 2, and type 3.
Okay.
And I think I've
Maybe
read the
they
same book.
mean, yeah, okay.
Yeah, means I agree with Dr. Raki. Now they don't differentiate these types. So means it's very some literature does it, but now WHO doesn't do it that details. So I agree with Madam. Yeah.
I think it is given in Merck manual, ma'am. We read it when
Okay.
we were in first year
Yeah.
PG. Merck
Okay.
manual gives that type 1, type 2, type 3 sideroblasts, where
Okay.
based on the number of granules present in the cytoplasm, they are classified, and type 1 and type 2 are considered to be non-neoplastic, whereas type 3 is considered to be associated with MDS. And as
Okay.
I said, it is not recognized anymore. That's why it is not there in the newer textbooks, newer editions of the textbooks.
Right.
So, ma'am, there is one question. How to distinguish from alcohol-induced sideroblastosis?
I think history maybe. Morphologically, I don't think. I'm
Yes.
not sure if there is any particular morphology.
Yes, ma'am. I
What
think.
is the question?
yeah.
What is the question?
Sir, question is how to distinguish from alcohol-induced sideroblastosis?
No. No, this is not morphology. Won't help. No.
Yes. Yes, sir.
Okay.
Yes, ma'am.
Any
Thank
more
you so
or
much,
can
ma'am.
we?
Next case we can, I think, move on.
Yeah.
Yes.
Okay. So who would like to discuss this case with me? The next one.
Ma'am, I can do.
Okay. Is it Ahle?
Yes, ma'am.
Ali. Okay. So would you like to read the history of this patient?
It is a 56-year-old male with a known case of people living with HIV on ART, and he's diabetic. He has complaints of easy fatigability, dyspnea on exertion, multiple joint pain since 1 month, and low-grade fever since 3 days.
Okay. So with this history, anything important for a hematologist, or what
He
would
has
have
all
prompted?
complaints of fatigability, dyspnea on exertion are the signs of anemia.
Okay.
Ready. And also he has fever, and he's on ART, which could give hint of some opportunistic infections affecting.
Okay. So you would think that yes, maybe marrow would be indicated at this stage. Okay.
Yes.
But not enough. So what about the hemogram and biochemical parameters?
His
You can just-
the hemoglobin and the RBC counts are on the lower side.
Okay.
His platelets are normal.
Okay.
WBC counts are also lower, so which indicates a bicytopenic picture.
Yes.
Also, his reticulocyte count is slightly on the lower side.
Okay. And biochemical parameters, do they look normal to you, or you find something abnormal?
The total bilirubin is slightly raised.
Okay.
Um,
Is it
LDH
diabetic?
is
Yes.
his of course his glucose levels are very high.
Okay. And you were saying LDH? Yes.
LDH levels are raised in his.
Okay.
Liver enzymes
So
are also slightly on higher side.
yes. Yes.
I said
Okay. So let me pose the questions to you now. It was at the end. Yes. So what was the indication for doing a bone marrow? Because with this much only an indication would come. You have to decide whether to do or not. So what do you think is the indication?
refractive anemia with bicytopenic picture and
Yes. So PLH patient with a history of fever additionally also.
additionally, yes.
Yes. Yes. So you have already seen the pictures. So what did you think the aspirate and the special stain showed?
There was the aspirate showed this erythropoiesis with a lot of erythroid precursors were seen, megaloblasts were seen,
Okay.
micronomoblasts were seen. The special stain showed a positivity. There was a positivity in the pearl stain. Also, ring sideroblasts were seen in the pearl stain.
Okay. Anybody differs among those who have seen it closely?
And plasma cells
Yeah.
I could see increased plasma cells.
Okay, so somebody thought these a lot of plasma cells. We'll see. Any other thoughts?
One of the slides showed increase in pro-erythroblast, ma'am.
Okay, so you felt one of the slides showed pro-erythroblast.
And
Did you think
in
plasma
specific
cells?
state-
Plasma blast. I thought plasma blast.
Okay, somebody thought they were plasma blast. Okay, and some of you
in
thought these were
persistent
erythroblast.
also, ma'am, there was diffuse positivity in some erythroid cells and some
Okay.
granular positivity as well.
Okay, so you felt it was a special stain showing pass in the erythroid, showing positivity. Okay.
Yes.
Any other thoughts? Okay, so with this, we have this opinion that some felt these were plasma blasts, some of them thought these were proerythroblast. We'll see it. And what did the biopsy show?
Biopsy so
Markedly
diffuse.
the cellularity was
Yes.
increased. There was a megakaryocyte close to the trabeculae. There was predominantly megaloblastic erythropoiesis, and also there were these blast cells for which CD34 stain could be done.
Okay, so you felt it was very cellular and these look like blast cells to you. Anybody else?
Cysts of blast,
Yes.
atypical,
Sheets
immature
of
cells.
blast, atypical. Okay, fine. So we'll go to the additional test when it comes. So let us see the morphology. So this is the aspirate. What do you think the cellularity is?
It's slightly adequate and slightly increased.
Okay. So it was in fact a very cellular marrow.
Cellular, yeah, for
So
age.
considering the age, yes. And these are the cell trails. So what is it preferentially showing? Which lineage of cells?
Erythroid series.
So what are all these cells?
Erythroid
Plasma cells.
Okay, so again we have between erythroid and plasma cells. Now let me point out certain cells. These cells, what would you call them?
Erythroid.
Lucky, would you like to use the pen or no?
I think I'm okay, sir.
Okay.
So these are hemoglobinized, right? So here we don't have a doubt that these are erythroid. But these ones have blue cytoplasm, right? So you have a confusion with
Plasma.
plasma cells. So let us look at some more. So in this field, what do you think? Plasma cells or erythroid? Where will you? Erythroid. So Rituraj feels erythroid. Anybody who felt these were plasma cells?
Ma'am, I did.
Okay, no problem.
Yes,
Why
ma'am.
do you feel they are plasma cells? They are plasma cytoid looking to
Cytoid.
you?
Yes, plasma
Okay.
cytoid, ma'am. Basically.
So there's abundant amount of pale basophilic cytoplasm, but I'm not seeing a HOF. But if plasma cells, are they mature or immature to you?
Ma'am, immature.
Sure.
Okay. So let us look at some more pictures. Now here, in this.
Nuclear budding.
Multinucleation.
Denucleation.
Multinucleation by nucleation. Right. And here, now at a closer look, the same multinucleated cell is there, and these are the other cells. What do you think?
Erythroblast.
So now it starts looking a little more erythroid here. Yes, the chromatin and also the basophilic cytoplasm here. And you have seen a tendency for hemoglobinization in some of the cells where it is appearing greenish tint is coming. Okay. This of course is a hemoglobinized cell. Okay. But look at this one and look at this one compared to this. Okay. So there is a blush of that hemoglobin coming in. Okay. So morphologically, it appears to be more erythroid than plasma cells, but I agree in low part, it was looking plasma cytoid. Okay. So this was a special stain given to you. What special stain is it?
MPO. Maybe.
Okay, something, this is kind of black, staining the granules
SBB.
black, so which?
Sudan black.
SBB. So this was actually a Sudan black, SBB stain. And what is it showing? It's a
myeloid series cells.
Yes, it is actually probably a neutrophil here. So granules are seen. So this is serving as a internal control. Okay. And hardly any other myeloid cells, maybe one here, but these other cells are
Negative.
negative. And can you see the number of mitosis in this field?
Decreased.
This one.
Yes. And did you notice that there was a lot of dyspoiesis in the discernibly erythroid cells in the low power, the cell trail in the first slide? You had noticed that, no? There was dyspoiesis. I can just quickly
Yes,
go
ma'am.
back
Yes,
here.
there was a
This one.
See, there was
yes.
this kind of mitosis, this
Binucleation
binucleation,
budding.
Budding and
so there
mitosis.
was
Circulation.
dyspoiesis. Yes. So there is erythroid hyperplasia. There is, what kind of cells are these? Would you want to call them what stage of erythroid? Now that we are kind of more or less convinced they are erythroid, which kind of erythroid are these?
Ma'am,
Erythropoiesis.
early
Early or?
intermediate.
They are not intermediate. Intermediate will show hemoglobinization. So
Yes,
those
yes.
which are not showing are early and
Early.
pro-erythroblast. Okay.
Pro-erythroblast.
Yes. So you have pro-erythroblast. You have erythroid hyperplasia with a sizable proportion of pro-erythroblast, and this is a SPB stain. And next, I have not written what stain it is, but one of you said, so what stain is it?
It's a past stain.
Stain.
Correct. It's a past stain, and what is it showing here? And what are
Granular to
these
block
cells?
positivity and diffuse.
Yes. So this cell is what? These two.
Neutrophils.
Neutral.
Very good. These
Mixture
are
of
neutrophils.
cells.
These are controls. And you are seeing the past positivity in the, in which cells?
Erythroid
These are
series cells.
erythroids.
Erythroid.
So what? Yes. So what is it a feature of? If you're seeing past positivity in erythroid?
Dysplastic erythroid.
Yes. So dyspoiesis. It's a feature of dyspoiesis. Okay?
Erythropoietic. Sorry.
Yes. So are you convinced so far that this is erythroid and dyspoietic erythroid with pro-erythroblast? So this is a closer look. Okay, a large cell, it had this vacuolation in some of them and this post granular and block positivity. Okay. And this stain is pulse. So it is loaded with iron.
Grade 6.
And one of you said that yes, you would look at the cell trails. And what is it showing now?
Ring sideroblast.
Sideroblast.
Are you seeing ring sideroblast here? Where is it?
Sideroblast.
Is it there or not there?
It's not
It
very
is?
neatly.
So there is no ring sideroblast here. There is iron in a macrophage. Okay. These are clumps of iron in a macrophage. Before this, sir had also shown you rhophocytosis, where you have a macrophage and the surrounding erythron. So the erythroid are not showing ring sideroblast, but there is a good load of iron in the marrow. So there were no ring sideroblast. Okay. I don't know. It has got stuck suddenly.
Yeah, it's moving.
Okay.
It's moving now.
Yeah. I am declining the annotation
Please-
request now.
Yeah, please decline.
Yeah.
I request
So what
students,
are your
don't disturb madam with annotation requests. Please don't do that.
So what are your thoughts on this case now? Now you have seen the morphology. What do you think? What is your diagnosis?
There is a severe dyserythropoiesis.
Okay. Yeah, go on. Give it beyond
It could,
morphology
there are-
diagnosis.
This with erythroblastic malignant leukemia.
Okay.
Could be
Pure
one of the-
erythroid leukemia.
Pure, yeah.
Okay. Okay. So these are your thoughts. Fine. So now you are thinking of something like a
Pure.
pure erythroid leukemia. So what was the terminology earlier and what is the terminology now? In earlier WHO 2008, pure erythroid leukemia, you had to have more than or equal to 80% erythroid with no, okay, with no evidence of significant myeloblastic component. And of course, we had a erythroid myeloid leukemia also. But in 2016, more than 80% of the bone marrow cells are erythroid, which is as before, with more than or equal to 30% pro-erythroblast. Okay. So with this, does this case fit into pure erythroid leukemia? Morphologically, there was erythroid hyperplasia, more than 80% was erythroid,
Yes.
more than 30%
were
were
pro-erythroblast.
pro-erythroblast, and there was definitely dysbiosis in the erythroid lineage. Okay. So our thoughts are towards pure erythroid leukemia. So let me ask you a little, in new WHO, where does it come?
6.
Okay, it is M6. So it was acute erythroid leukemia. It had become
No.
pure erythroid leukemia. It's again acute erythroid leukemia. So there is no erythroid myeloid now. No, we have removed that.
Yes.
Yes. Okay. So this is among one of those which are morphologically defined. Okay. We had the sample and we were also curious. So we ran a flow cytometry on that. So the lineage markers for myeloid B and T were negative. CD34 was also negative. HLA-DR, some positivity was there. But otherwise, as I told you, most of the lineage markers as expected was negative. But CD117 was positive. Okay. And we did this CD235A, which is a, what is it? It is basically glycophorin. So it was positive. Okay. So this was the biopsy given to you, and what you saw was, as you had said, that there were sheets of blast.
Yes.
So if this is a trabeculae and these are blast, what kind of blast do you expect them to be in a normal marrow? Or myeloblast. So myeloid blasts are actually paratrabecular in location, but they never so, the thickness is not of so many layers. Okay. So such bulge of myeloblast you'll see when there is CML or a very, a myeloid neoplasm. Okay. So these look like blast and they're paratrabecular. And in the intertrabecular region also, there were these cells which are blastic, but now we are seeing some erythroid maturation in between. Okay. So these are admixed with erythroid. So definitely if you see only the trifine, there is a confusion whether these are myeloid or erythroid. So that doubt we have to resolve, maybe IHC, but when you are seeing them mixed with the other erythroid lineage, you think of erythroid, and here they are in sheets. Erythroid tend to be in colonies, but here the cells are in sheets. And some megakaryocytes, here there is some lobe separation here. So like dysbiosis. And what is this stain? This is CD34. And what is it staining here? Again?
Endothelial cells.
Yes, so endothelial cells control. So what about the blast? These are negative. And this stain is, what is this? E-gathering. And it is nicely highlighting all these cells. Okay. This is in the intertrabecular region and also in the paratrabecular region, which is not a normal location for erythroid blast. Okay, they tend to be towards the away from the trabeculae. And in colonies, here they're in sheets, they're near the paratrabeculae. And you can see these are all blast. You can appreciate sometimes the nucleolus is prominent. So that helps to distinguish from a myeloid blast. Okay. In addition, CD117 was also positive. This was also positive in flow cytometry. Okay. So are you convinced of calling it a pure erythroid leukemia with this?
Yes, ma'am.
Okay. And we also did a MPO. So what is it highlighting? These are basically
Granules of
granules. So they're residual myeloid cells. Okay. They seem to be obscured because of the overwhelming erythroid, but they're there, much less. And they are actually nicely, strongly positive. In fact, myeloid blast, the MPO tends to be weaker and not so granular. Okay. The myelocytes, maturing elements tend to be more strong. Okay. So what would you want to do next if you are thinking of a pure erythroid leukemia?
Cytogenetics.
Cytogenetics. And do you know which kind of cytogenetics? What is the prognosis of this? Usually these are associated with complex cytogenetics. Okay, so in this case, there was complex karyotype. Okay,
Loss of
so this
seven.
patient had a complex karyotype, and you know which mutation is very strongly associated with pure erythroid leukemia? If you had to do
Immersion.
one IHC, which IHC would you want to do? Which IHC marker will help you?
E-cadherin.
E-cadherin will help you in telling it's a erythroid.
Erythroid lineage.
But suppose you are having reactive erythroid, you are having megaloblast. If you are megaloblastic anemia will also look full of erythroid and they will look like blast. So
P53 is 10. P53, ma'am.
P53. Okay. Glycophorin also is a marker of erythroid, but
Erythroid.
does it help to distinguish reactive versus neoplastic?
No.
So P53 is very strongly associated with this malignancy. Okay, this patient had a post-induction marrow after this one cycle of azacitidine and venetoclax, but marrow still showed persistence of these blasts, erythroid blasts. So are you convinced that marrow is not in remission? And this patient also succumbed after few months. Okay. So what are the distinct features of this pure erythroid leukemia? So as I said, this one actually, if you see myeloid neoplasms with erythroid hyperplasia, this is one among the other myeloid neoplasms where you have an overwhelming erythroid component. And it is very difficult to sometimes distinguish this even from reactive conditions. Okay. But among the neoplastic proliferations involving erythroid, this pure erythroid leukemia has a very poor outcome. Okay. So independent predictors of death are morphologic features of pure erythroid leukemia, poor cytogenetic risk, hypoalbuminemia, and high serum LDH. So our patient did have many of these. There were features of PEL, poor cytogenetic risk, high serum LDH. Okay. And I don't recall what was the albumin, but maybe it was lower than 3.7. Okay. So now coming back again to a problem. When you have this kind of erythroid in the marrow, it is very important to distinguish reactive erythroid proliferation. You cannot straight make a diagnosis of pure erythroid leukemia just because there is erythroid hyperplasia. Okay. So when the reactive erythroid proliferation will pose challenges is when it is megaloblastic. Okay. When it is megaloblastic, you are thinking whether these are pro-erythroblast or not. They all look like blast, but megaloblastic will have megaloblastic pattern of maturation. Then when there is a left shift or arrest in maturation, dyserythropoiesis. So clinical context is important. This is one of our cases, a post-chemotherapy bone marrow, and it just shows early erythroid, okay, pro-erythroblast. Maturation is less. Marrow is hypocellular, but it just shows this, okay. So what are the morphologic clues? Like I showed you, in pure erythroid leukemia, these erythroid are in sheets, okay? But in reactive shift, they are in small clusters or single cells, which are intermingled with other marrow elements. So erythroid proliferations in the myeloid neoplasms are haphazard. When it is neoplastic, they don't form erythroid islands. But when it is reactive, erythroid has a tendency to form islands or colonies. But when it is neoplastic, it tends to be more haphazard, okay? And it's also said that they tend to be smaller, contain more dispersed chromatin. Cytoplasm is frequently vacuolated. These are soft pointers, but on a biopsy, as I said, sheets and a tendency to form colonies are a clue. Okay, and as we already discussed, any robust IHC, yes, P53 very strongly associated with pure erythroid leukemia. It has uniform strong P53. Okay, so this was the P53 IHC in our case. Our case which I just showed you, look at the strong P53. So this would indicate a mutant P53. But in other cases, these were some of our other cases like autoimmune hemolytic anemia. This is the first case I showed you. And you notice in that biopsy, you were seeing erythroid maturation. But in this biopsy, they looked more like blast. And this was that post-chemotherapy. So in all these cases, P53 is minimal or negligible, less than 5% or so. You can hardly 1 or 2 nuclei, but here it is uniform strong. So this is one important IHC marker if you are thinking of a pure erythroid leukemia, especially to distinguish from non-neoplastic erythroid. So can you identify him and what link does he have with this theme that we just discussed, the two cases? Who is this? Anybody?
No idea, ma'am.
No idea?
Sorry, ma'am.
Bone marrow neoplasms with erythroid predominance was described by D. Guglielmo in 1917. And this entity was called D. Guglielmo's disease. Okay, for a long time. Okay, fine. So that is the end of the second case. So now you agree these are too many E residents, or E stands for erythroid. Both the cases were erythroid
True.
hypoplasia.
Yes, ma'am.
Okay, so any questions now?
There are a few questions in the chat box. One
Yes.
question is how to differentiate between a pro-erythroblast and an early megaloblast, and also how to differentiate between a pro-erythroblast and an early normoblast.
Okay, now it's very important to distinguish megaloblast from proerythroblast. So megaloblast will show megaloblastic maturation. Look at the chromatin pattern. If it is sieve-like, opened up, it is megaloblast. But if it is not looking sieve-like, it is a normoblast. In that, we call it proerythroblast and early normoblast. So proerythroblast is a earlier stage than an early normoblast. It tends to have more opened chromatin. And it's a, I would say it's a continuum, but you can make out that, but both of them do not have hemoglobinization. Hemoglobinization will start only in the intermediate or orthochromatic. Okay. So that is how you will distinguish it.
Thank you, ma'am.
Any
There
other?
is one question again in the same theme as it started. Could we still think of lymphoplasmacytic lymphoma based on just the HND morphology? That is one question.
Yes, just the few slides of the bone marrow aspirate, definitely some of you have thought of it as plasma cells. You can think of plasma cells, but like seeing all the fields, seeing that erythropoiesis, seeing that some of the cells have hemoglobinization. So if you see sometimes, you know, when you give a slide for 5 minutes in an exam, people confuse between plasma cells and erythroid, megaloblastic anemia. These are, but you have to, I mean, see further and do some cytochemical stains or do a CD138 or 38 also.
Yes, ma'am. Thank you, ma'am. I think Gujral sir is also answering a lot of queries in the chat box, so
Okay.
that many people will be satisfied. And if there are no more questions, I think, ma'am, we can move on to the next case.
Okay. This is a relatively shorter case, so we will finish soon. And who would want to discuss this? Anyone volunteering? Vidya is there?
Yes, ma'am.
Vidya, Pinky. Okay. So would you like to read the history, Vidya?
Yes, ma'am. 28 years female. Para 3, live 3, 2 aborted. Postpartum, 5 months. She presented with a history of melena since 1 month, hematemesis 10 days, and bleeding per rectum 1 day. And also she's showing the signs of like worsening fatigability, tiredness related to anemia for past 2 weeks, and complaint of purpuric rashes in both upper and lower limbs for past 1 week. So on examination, severe pallor is present. No other significant organomegaly or lymphadenopathy or icterus.
Okay. So with this history, what do you think?
So here one, she's signs of anemia are present, ma'am.
And
Then also
a whole lot of bleeding manifestations, right? So yes.
purpuric rashes.
Yeah, so lot of purpuric rashes are there and there is bleeding from so many sites. So you expect that maybe 2 cell lineages are involved. Okay. With this history, it could be anything. Very difficult to pinpoint on a diagnosis, but You can think of so many hematological conditions also with this history, okay? Even aplastic anemia but there is a short history of this worsening, okay? So now this was the PS given to you. What do you think are the CBC parameters and what is it in the PS?
Hemoglobin it is decreased, ma'am. RBC decreased. RBC index, red cell indices, MCHC is decreased. Then RDW wise it is increased. And WBC count it is increased, ma'am. Corrected WBC 18,000. Then platelet count is decreased, ma'am. Severe thrombocytopenia is present.
Yes.
So,
And
Elevated
additional,
RBC.
so there is anemia, there
MR
is a neutrophilic leukocytosis and markedly reduced platelet count. Anything additionally you are seeing in these smears? What are these cells?
Nucleated.
Are these agglutinated or what are these? These are having a
Polychromatic cells.
polychromatic. These are having a bluish tint. So there is polychromasia. And what is this cell?
Nucleated.
Nucleated red cell. Yeah. I am sorry for the artifactual changes, but these are the slides which were there for this case. So there are many nucleated red cells and marked thrombocytopenia. Okay. And no other atypical cell. Okay. So you have already seen the bone marrow aspirate and biopsy. You will tell what were your findings and how will you explain the peripheral blood findings with the history provided and the. So what? So would you like to answer, Vidya or Sherry, whoever?
Ma'am, on bone marrow aspiration, we could see the cells of the myeloid and the erythroid lineages, but no any megakaryocyte was appreciable.
Okay. All right. And how will you explain the peripheral blood findings? There is
microcytes, macrocytes, polychromatophores are there, ma'am. And here.
okay. So there is marked thrombocytopenia. Patient is having bleeding manifestations. So it could be anemia of blood loss also, which will explain the NRPCs and polychromatophils. And of course, nutritional deficiency can be coexisting. Okay. So the marked polychromasia and NRPCs in addition could be explained by the blood loss. Okay. So this was so this is the bone marrow aspirate. We had a particle this side and the nicely cellular trail here. Can you make out a lot of erythroid colonies with good amount of maturation? So normoblastic maturation.
Yes,
Okay, so normal erythropoiesis, you agree with that?
Yes.
Yes, and you are also seeing myeloid with normal pattern of maturation. So sequential maturation. There is another field here again. And this is actually to show you in the low par because what we are looking for is megakaryocytes here, which are conspicuously missing. Yeah. Yes. So you have picked up. So what is this? You earlier saw it also. This is a erythroid island, no? A macrophage with the surrounding erythroid. Yes. So we are seeing nice myeloid maturation, erythroid maturation, but no megakaryocytes. And similarly, this was the biopsy given to you. So this is a trabeculae and near this part is the paratrabecular area. Yeah. So even at this power, you would expect to see some megakaryocytes. They are missing.
Yes.
And looking farther away also, they tend to be missing here. Okay. So do you want to confirm whether megakaryocytes are there or not? Would you like to do some IHC? So you can do, yes. So it is better to do an IHC because sometimes you just by morphology, your eyes may miss it, but it's always good. So this is CD 61 and again, no megakaryocytes. And what is this actually? I have labeled it. Which stain is this?
Factor VIII.
Yeah, I think that was factor 8. It's, yes. Yes. Yeah. So again, it is staining some of the endothelium here, and after hunting, there's just one cell with a semblance to a megakaryocyte. So maybe this one in so many slides I could make out on the IHC. And yes, again, you should do a CD34 because sometimes it may be masked, but no increase in blast. And E-cadherin highlighted the erythroid islands. Okay. But conspicuously absent are the megakaryocytes. So this case would fit as a case of A megakaryocytic thrombocytopenia. Yeah, and going with the history, it could be a case of A megakaryocytic thrombocytopenia, which is also known to have a immune mediated etiology. Okay. So morphologically, we would call this a megakaryocytic thrombocytopenia. Yeah, so sometimes these patients do have some, sometimes with SLE and one. Okay. So this was the final diagnosis. So with that, we come to the end of the slide session. So these two cases had something missing, case 3 and 4. So here it was A megakaryocytic thrombocytopenia. And the first case Basu sir showed you was pure red cell. ERCA, okay, pure red cell aplasia. So with this, I think we come to the end of the session. So any questions here?